You're listening to the Patient Advocacy Now podcast, presented by Greater National Advocates.
It's just gut-wrenching sometimes. Like, if it's sad and they're crying, I might cry.
Amazing how many doctors do not even want to treat somebody who has Medicaid.
Medical system is about making money.
And I said, so are you hiring more nurses, or you're just telling each nurse to work harder?
Dr. Nicole Rochester, thank you so much for being on the podcast.
Thank you for having me, John.
You are a doctor. You're a pediatrician, and it's always so fascinating to me to talk to physicians who get into the advocacy space. So let's start there, because you have a lot that you do, a lot that you've kind of branched out in within the advocacy space. But let's talk about how it even started for you.
Sure. So I am a pediatrician, as you stated, and I was practicing medicine for almost 20 years when I made the transition to health advocacy in 2017. And I didn't do it to run away from medicine. I actually loved my job. I wasn't experiencing burnout. I was looking forward to what I thought was going to be a lifelong career in medicine. But my late father, who had a lot of chronic health conditions, really became pretty ill in 2010. And my two older sisters and I had to fairly suddenly and abruptly start helping to care for him. And we kind of fumbled around initially trying to figure out who would do what. And then eventually we decided that as the doctor in the family, I would be the one to oversee his medical care. So I started going to his healthcare appointments, and he was in and out of the hospital and the emergency department. And for 3 years until he passed away in 2013, I saw the healthcare system from a completely different vantage point. And I was like overwhelmed and disgusted and frustrated and all the things. But what I noticed pretty early on is that my experience and my expertise and background as a physician was a privilege in that caregiving situation and from my dad. And there were so many instances where I found myself asking questions that I knew the average layperson wouldn't know to ask, or escalating matters because I knew exactly how hospitals worked and I knew who to ask for. And so I saw my dad benefiting from this and wondering, what is everyone else doing? And understanding that as difficult as it was for our family, I'm a physician, one of my sisters is a nurse. We were still struggling, but also thinking, every time I would navigate some system or some problem, using my medical knowledge, or even frankly, just my pull, like my what do you call it? I guess my connections. Yes, my connections. Exactly. Right. And then I would say, okay, like this went well, but it's only because of my position. What about everybody else who doesn't have a doctor in their families? So before he passed away, I was really starting to think about how I could do this for other people. But as you know, John, like you spend your whole life becoming a physician. And so the idea of leaving medicine was not even on my radar. But a couple of years after my dad passed away, I just really started feeling strongly that there was something else that I was supposed to be doing. And once my friends and colleagues knew about my experience with my dad, they started reaching out to me saying like, hey, now my mom is sick, or my dad's in the hospital, or my grandmother has this. And what did you do? And so people started coming to me over and over again for advice and insight. And so I just started thinking, okay, what would it look like to do this for other people the way I had done for my dad? And that led to me starting my own business and leaving medicine, and I haven't looked back.
And when was that? What year was that, where you left medicine as a practicing pediatrician?
That was in 2017. That's when I started Your GPS Doc. And initially, I kept my foot in the door. I did some moonlighting shifts and, things here and there because I really did want to continue to practice medicine. But then eventually, as the business took more of my time, I was able to leave medicine altogether.
So talk to me about what your work as an advocate, just on that part of your world right now, as an actual hands-on advocate looks like. What population do you work with? Is it 20 hours of your week? Is it 90 hours of your week? Do you do virtual, in person? What does it look like? And what kind of advocacy is it? I mean, are you doing medical navigation? Are you doing kind of alternative diagnosis options? I mean, what is it that you, because of your background as a physician, it could be kind of a million things.
So true. That's very true. I primarily do medical navigation. Now, when I first started, like many advocates, I didn't know what I was doing. I mean, I knew what I was doing, but I didn't know what I was doing. I didn't know what I wanted to specialize in. And so I think myself, like a lot of us, we do a little bit of everything. So in addition to medical navigation, I was helping people with their health insurance policies, helping them to understand, helping them to choose health insurance. I did some cases with appeals, insurance denials. Now in 2025, there are people that do that, way better than I do. And there are people who have that as their expertise. And so now I really do leverage my medical degree by focusing on medical navigation. And that can look like a lot of things. I really like to help clients and their family members make sure that they have a clear understanding of their medical conditions and how to receive appropriate care. I also really like to help them bridge communication gaps. A lot of times when clients come to me, they think that they're receiving inadequate care, but sometimes they're not. Sometimes they're actually receiving great care, particularly when they're in the hospital, but they don't know that because no one's talking to them. They're
Right.
having a hard time getting all the different players in the room. Their family members are frustrated because when they show up, the doctors have already rounded. And so sometimes it's really just being that liaison and between the client and their family members and the medical team. Sometimes it's walking them through a new diagnosis and helping them to form their medical team. And sometimes it's researching facilities. I have a client now who is hospitalized and is going to need subacute rehab. And so I'm working with her to research subacute rehab facilities based on the unique needs that she has. So that's what I tend to focus on is, helping people understand their diagnosis, helping them navigate the system in which they receive care, giving them tools to ultimately advocate for themselves, because I really like to be able to not be needed eventually. And I like to give them skills and tools so that once they're through whatever the acute situation may be, they can kind of pick up the helm and do this on their own. And in terms of who I serve, because I was a family caregiver myself, and that's still such a huge part of my identity, and that's why I came into advocacy. I love working with family caregivers. I love working with adult children of aging parents and, spouses and partners. And also, I often end up working with, the person, of course, who has the healthcare problem. And the interesting thing is that my client population is almost exclusively older adults and those who care for them, even though I'm a pediatrician. So I don't do any
Yeah.
pediatric advocacy. All of my advocacy is with adult clients.
I think that you see that quite a bit in the advocacy space. That's where complex diagnosis comes in. That's where chronic issues start to emerge. That's where, as you age, you get a punch card, and after 10 visits, you get a toaster at the doctor. You're there. You're there quite a bit. Sorry, makes sense. Makes sense. And is your work mostly virtual? Are you actually going to the hospitals? Do you serve people all over the country?
I'm located in Maryland, but even in the beginning, long before COVID, I was doing most of my services virtually. I think that's one of the many things that I love about health advocacy is that I can serve clients all over the country. I'm not limited by any geographic barriers. So the majority of my work is virtual. For those clients that do live in the DC, Maryland, or Northern Virginia area, I am happy to provide in-person services when needed. But even in those cases, even with local clients, I have found that the majority of the work that we do together can be done virtually.
That's great. It's great for everybody because obviously it's a great lifestyle for you, but they don't need to wait for traffic and parking and meet you at a certain location. It's like, let me just call Dr. Nicole. Like just let's just schedule something. That's a beautiful part of it, I'm sure. Okay, so that's a huge part of your life and business now, but you've branched out of just being an advocate, hands-on kind of boots on the ground or virtually advocate. What else are you doing? Because you're doing some fascinating stuff on kind of the training side.
Yeah. So a few years into doing this, I started getting tagged in some of our physician Facebook groups by doctors who wanted to do what I was doing. And the funny thing is, even now, I mean, I just spoke to a physician a couple of days ago. There's still a lot of people within the healthcare system and outside of it who don't know that health advocates exist. And so periodically, there'll be a post in one of the groups where a doctor is either frustrated with their job and wants something else, or they may just say, is there like a career where I can just help patients understand their medical conditions and help them, navigate the healthcare system? Like they'll literally say it like that. Like, is there something? Can you get paid for that? And then now, other doctors who know me will say, "Oh, you need to like Nicole Rochester is the person." So I started getting tagged in these Facebook posts, and I had doctors reach out and say, like, "Hey, how did you do it?" And so I would hop on phone calls and Zoom calls sometimes for multiple hours. And then as I've gotten busier, I no longer had that capacity. And so then I had a doctor, probably this was like 2020, say, "Well, can you just coach me?" And I was like, "No, because I'm not a coach." And so I turned her down. And then I had another doctor a couple of months later say, "Well, I know you don't have time to, do this for free. Like, I'll pay you. Can you just coach me?" And I kept saying, "Nope, not a coach." And then finally, by 2021, I was like, wait, maybe I could be a coach. I mean, at that point, I had 4 or 5 years of experience doing this and had, figured out a lot of things by making mistakes, what I now call lessons. And so initially, I just kind of did a couple of one-off coaching sessions with a few doctors, and that led to 4 or 5 sessions. And then that led to me developing a formal program that was still one-on-one that I hardly ever talked about. But if somebody came to me and said, "Would you do it?" I would say yes. And now I have a small group coaching program called Navigating Health Advocacy Ready, Set, Launch, specifically for physicians who want to launch a successful health advocacy business. So we just started our 8th cohort 2 days ago, and I've taken about 34 physicians through the program. And it's been amazing to be able to transfer this knowledge and to be able to accelerate the path. Because for me, it took me a long time to really figure out not how to do advocacy, but how to make it a successful business and how to properly price my services and all the things. And so now I'm able to pass that on to other physicians and, with the hopes that they will avoid some of the challenges and some of the mistakes that I made and have a more straightforward path to success and, more importantly, to impact and to helping clients.
Yeah. I think it's so interesting that you're focusing on physicians, not just because obviously that's your background, but they know the medical part, right? They know the navigation. Maybe they need to know some of the boundaries because it's different as a doctor and an advocate. Yeah. So there's some boundaries they have to kind of respect. But again, I think that's kind of the quick and easy part that you can probably, or I shouldn't say quick and easy, quicker and easier part for a physician. But you're probably spending a lot of time, like you said, on pricing, marketing, positioning, how to actually build the business, build the reputation so that they have something that has legs and can move. Is that right?
That is right. Yeah, there's a lot of, tactical, strategic information and guidance in the coaching program. But interestingly, John, the majority, I mean, that stuff, that's in the modules. They have videos. They can go back and watch that over and over again. What we spend a lot of time on is mindset. And I think when I began coaching, I started to really unpack and uncover all of the mindset shifts that I had to make in order to be successful. Because as a physician, and this is probably true for many other professions, but I can speak to physicians. One, we're not taught how to run businesses, and that's probably by design, but that's another conversation. And so we're taught to just kind of, be the cog in the wheel and follow the rules. And so as talented and as brilliant as we can be, we have mindset blocks around being successful and being able to go out on our own. So you'd be surprised how much I talk about just this idea of like, you can do this, because a lot of physicians, they've done so many hard things. They've literally saved lives, but they come into the program with a lot of doubts about whether they can be a successful business owner. And so we talk a lot about kind of some of the things like perfectionism and wanting to always be in control and not wanting to make mistakes and having a low tolerance for risk. Those are things that are important in the medical field when you're, an actual clinician, but those are the very things that can trip you up when you are running a business. You have to put yourself out there. You have to be willing to, make mistakes and learn from those mistakes and pivot. So we spent a lot of time in the program on mindset as well. And then, like you said, the boundaries, because we are not practicing medicine. We're flipping from being the doctor to being the consultant. And so we talk a lot, and I give very specific, scenarios. We do some role playing so that they can understand what that looks like to show up as someone who happens to be a doctor, but you're not their doctor.
Right. From patients to clients, it's a whole different
That's right.
kind of ball game. How long is your coaching program typically?
It's an 8-week program, and it's a combination of asynchronous, like videos and downloadable resources. And then we have live coaching calls every week to do a deeper dive and answer questions. And then the thing I love the most, one of the many things I love about it, is that we have a community for alumni. So we have a Facebook group and other ways that we stay connected. And so we share resources. I'm watching them, shine, and they get their first client and they have questions. So we're building this community of physician advocates, which has been really great.
It's amazing because we need more physicians in the advocacy space for sure. And as your kind of proof here, evidence that it can be successful and fulfilling and kind of check the boxes that so many doctors, especially ones who are burned out, really want to kind of check off. And 8 weeks, it sounds like what the coaching program really does is it takes the 3 or 4 years that it took you and condenses it into 2 months.
That's
and
exactly right.
And so you're just kind of cutting the line,
Yes. I need to put that in some of my marketing copy. That's great, John. Yes. Cutting the line.
Yeah. Okay, great. Yeah, I hope more people hear about it. You also have done some speaking, and I think that that's one thing that I wish that hospitals and kind of the systemic issues that are existing in the healthcare system would look to other advocates to do more of in listen, we have some great conventions and conferences for advocacy, but I'd love to see it because there just aren't enough people who know what advocacy still is. It's still this emerging kind of nomenclature. Talk to me about the speaking. I saw you did a TED Talk and you've done other speaking as well. How did you get into that? What do you typically speak on? And how has that impacted you and the people around you?
Well, I've been a speaker probably since I was 5. I'm the person that used to get in trouble for speaking in class, for talking. Who knew that, that meant I was going to be a speaker one day. I'm joking, but I'm actually being really serious. That's the one I could not get an A in behavior because of my talking. But the only time I couldn't get an A. But in terms of speaking, I guess more formally, as when I was practicing medicine as a pediatrician, my last role and a couple of roles prior to that was in academic medicine. So in addition to taking care of patients, I had the pleasure of teaching medical students and pediatric residents. So I did a lot of speaking in that context. There were talks that I prepared to teach the students and the residents and sometimes even nurses about different medical conditions and some of the things that we experience in pediatrics. So I think I kind of caught the bug for speaking in that capacity. But in terms of my advocacy work, when I first started Your GPS Doc, I was very concerned about the fact that there are a lot of people who need this information who will never be able to afford an advocate. And so I really wanted to figure out how can I get this information to the people who can't pay me to work with them privately. And so I started speaking in libraries and churches and community organizations, at caregiver conferences and things like that, just talking about how to navigate the healthcare system, how to navigate it as a caregiver, how to navigate it as a patient. So those were kind of the early speaking days. And then I've continued to do some speaking around that. In 2020, after the death of George Floyd and all of the other deaths and just kind of the whole unrest in our country, I started giving talks about structural racism and bias in healthcare, and had a lot of opportunities to talk in hospitals and healthcare systems and pharmaceutical organizations about how that shows up in our healthcare systems. And that really kind of catapulted me into a lot more speaking engagements. So I continue to talk about that. I talk about medical gaslighting. I share about my caregiving experience. And, I continue to talk about navigating the healthcare system. I talk about restoring empathy in healthcare, which is incredibly important to me. And that was the crux of my TEDx talk. So my TEDx talk, I had the opportunity to share about my experiences caring for my late father as a physician who, I understand the challenges that clinicians and, the healthcare administrators, I get it. Like, I understand that side of it. And I'm also, or I was a caregiver. And so being able to provide that perspective, and what it boiled down to for me was feeling like there was a lack of empathy in our healthcare system. And so the big idea for my TEDx talk was something I introduced as the 90-second encounter, which is this idea that the first 90 seconds of every clinical encounter will be spent just talking, like you and I are talking. Like, before you come in the room with your laptop or whatever and say, hey, what are you here for, John? Or what can I do for you today? It's like, how do we connect on a human level? And the idea is that when you truly connect with patients and when they are able to connect with you, it transforms that relationship. It builds trust. There's studies that show that it leads to improved adherence to the treatment recommendations, the medications, all the things that, we physicians tell our patients to do and then get frustrated when sometimes they don't do it. So I had a chance to really introduce that concept. And so I continue to talk about that. I've done workshops where we spend 45 minutes to an hour actually practicing the 90-second encounter and doing role play. And that's always a lot of fun to have pharmacists and physicians and nurses pretend to be the patient and see what it's like on the other side of things. So yeah, speaking has become a big part of what I do at your GPS doc. And it's a nice balance to the advocacy work and the coaching as well.
I get a good sense of what the empathy and the 90-second kind of connection is. And anybody who's gone to just even a regular physical and has 15 minutes with their doctor can I think appreciate what 90 seconds of dedicated eye contact, quality time of what's going on with you can really do. But you blew past a bit of a Pandora's box, so I'm going to go back a second. Racism in the healthcare system. Talk to me more about how that shows up, because there are people, especially ones who are struggling with navigating their own or a loved one's healthcare issue, that might be facing this, might not be understanding what it is or why it's coming up. Talk to me about what you've discovered and how you educate people.
Thank you. I appreciate the opportunity to share about that in more detail. What we know that there are health disparities. I like to use the term health inequities, because when you talk about a disparity, it's just saying there's a difference. So we know that, as an example, Black women are 3 times more likely to die from childbirth compared to their white counterparts. And that's regardless of income, regardless of socioeconomic status, education. And those statistics are evident in if you look at any disease, any type of cancer, heart disease, anything, Black individuals and in general, people of color have worse outcomes. And so the fallacy is that some would look at that and say, oh, that's because, and then insert, they're this, they're that, they don't do this, they don't take care of themselves. But what we know is that at the root of really all health inequities is bias and discrimination and racism. And when I say racism, it's important to note, I'm not talking about like the doctor is racist or the nurse is racist. I'm talking about more structural things. So access to care that differs based on where you live. And those things are built into, policies and laws that predate me and you. So there are a lot of things that are part of our literal system, the healthcare system and all other systems, educational systems, that really continue to create barriers for people who look like me. And so what that does is that leads to worse health outcomes. But then there also is bias. And so we know that all of us, literally every human, has biases. We've all been exposed to stereotypes. We've all been exposed to information about groups of people that, may or may not be true. And without always knowing it, that lives in our subconscious. And so there are lots of studies that show that, again, Black patients, Latina patients, patients of color, are not treated the same. The conversations are different. The length of the conversations are different. they're sometimes not offered treatments, clinical trials and even other basic therapies. When we look at protocols that are established, like for certain conditions that are even in the medical record, like algorithms and things that should go seamlessly, we see that Black patients and patients of color often are not receiving treatment. There's a study that shows that Black patients who have had a stroke spend more time sitting in the waiting room of emergency departments before they're seen. I mean, I could go on and on and on. Even in pediatrics, there's a study that shows that in pediatric patients who have appendicitis, which is, it could be a medical emergency, they are less likely to be given appropriate pain medicine compared to white children. So like these are babies, these are, kids, I'm saying babies, but so it even trickles down to the treatment of children in healthcare. So my talks really are not meant to blame or shame or make anyone feel badly. It's really to illuminate the problem and then to present solutions. And so I talk about on an individual level, we all have a responsibility to examine our biases and to regularly be thinking as we're engaging with patients, is there something I'm thinking about this person? Is there some belief that I have that might interfere with my ability to deliver the best care that I can? So that's like on the individual level. And then on the systemic level, are there policies that are in place that are disproportionately burdening patients with lower socioeconomic status or patients with, who have less resources? So just as a quick example of that, a lot of doctors' offices have policies that state that if you are more than 15 minutes late, that you have to reschedule. And sometimes they even charge you for the visit. Now that sounds like, I get it, right? Like they need to be able to move along. They want patients to take the appointment seriously. So I get why those are in place. But if you think about the fact that people who have lower income don't have a car, like it's easy for me to get in my car and fight traffic and get to a doctor's appointment. But if I'm taking 2 buses and then walking 6 blocks, it's more likely that I'm going to be late. And I have no control over whether that bus comes on time. If that bus is 10 minutes late, guess what? I'm going to be more than 15 minutes late for my appointment. And so when we look at policies like that, we can see that they disproportionately burden a patient population who doesn't have access to transportation. So it's really like doing those types of deep dives and then trying to understand, like, how do we fix it? How do we address those problems so that everybody has the best care possible?
Have you thought, I'm sure you've thought, I don't know why I asked, I'm sure you've thought of different possible solutions to many of those issues. I'm just curious if there's a high leverage one that you've kind of said, if this one thing would change, it would actually make a big difference? Or do you feel like it's too complicated to just point to one thing to do first?
Yeah, I really think it's too, it's not, complicated may not be the right word. I think that's the I'm going to say excuse that a lot of health systems use. And I'm not saying it's easy, but in some ways it is simple, because this has been studied, again, for decades. And we have examples of organizations and hospitals and health systems who are getting it right. But so I can't point to one thing, but I think the thing that would be the most profound is to really have a systematic way of examining policies and really figuring out, are they impacting all of our patients the same? Are there elements of this policy that in and of itself may seem fair that would cause certain patient population to be disproportionately negatively impacted? And if we did that with every decision that we made and with every policy, I think that would go a long way in starting to eliminate some of these inequities. And then the other thing is really accountability. I mean, it's not okay that year after year after year, I talk about statistics that show consistently, these vast differences in the way certain patient populations are treated, the way the care that they're receiving, the outcomes. And then, we just the next year, another statistic pops up and then we say it again. And so there's a lack of accountability for those types of outcomes. And so I do think weaving that in somehow is important for us to really see change.
Okay. Does that bleed over into some of the gaslighting, the medical gaslighting as well?
Absolutely. Yeah. Women are more likely to be experience gaslighting. People of color or more likely to experience gaslighting. People in the LGBTQ plus community are more likely to experience gaslighting. And a lot of that also, again, comes with these usually unconscious biases. And so, if you are not a minoritized,
Specific examples so people understand. I know what
yeah,
you mean, but let's, like, you're in the doctor's office, maybe you have a pain, and how does that, you can pick a symptom,
yes.
what, walk me through what that might look like.
Sure. So let's go with pain since you mentioned that, because that's one of the big ones. So let's say, if you and these are generalizations. So I don't want anybody listening to get, upset. But they're generalizations, but they're also what we see in the literature. And so for pain, if you are a Black male, as an example, and you go to your doctor, or you go to the emergency department or to urgent care complaining of pain, you are more likely to be perceived as a quote unquote drug seeker.
Mhm.
And you're more likely to be perceived as someone who is requesting pain medicine. You're addicted, you're trying to work the system. And so those pain complaints are often minimized. And we see that with Black people, with Latino people. So that's something that is very common. If you are obese, so there's biases against people who who are overweight and have obesity. So with those conditions, any single problem that they complain about often is attributed to their weight. And so they can say, I have a headache. Oh, you need to lose more weight. I have this, I have that. And people in my own family have experienced this. And I have friends and, even clients who have experienced this, where they had significant issues, but instead of investigating their complaint, the medical provider automatically, they see this person who's, has overweight, obesity, and they go, oh, this is, you just need to lose some more weight. And so there's a reluctance to even investigate a person's complaints, or sometimes their complaints are minimized. I mean, that's really at the crux of medical gaslighting, is minimizing someone's concerns about their own body.
What is that for patients who might be listening, or potential patients? What does that sound like out of the mouth of a physician? What does minimizing sound like?
Yeah, minimizing could be, I come to the doctor and I say, I'm having headaches and they're getting worse and I'm really concerned. And then maybe they ask a couple of questions, maybe they don't. And they say something like, oh, well, you're probably stressed out. You probably just need to, or they may ask a question to say like, well, what's your stress level like? And then, I have 4 kids and I just lost my job. Oh, it's because of your stress. And again, not even pursuing, sometimes not even an examination to see, okay, maybe stress is like, that should be the last resort. Like, you should do an examination. You should ask more questions. So, minimizing would be kind of attributing it to something else without doing a thorough examination, without doing testing that, another patient who maybe looks differently would get a more thorough workup. So that's one example. And sometimes it's literally ignoring, I mean, it's literally kind of, or always assuming that it's the least severe problem. And again, we're taught in medical school that this idea of like horses versus zebra meaning something rare. And so we're taught to kind of put people in boxes and to listen for these context clues, and then to say, oh yeah, you have this and this, you probably have that. So that in and of itself is not necessarily gaslighting, but when certain populations of people are treated that way, systemically, and they're more likely to be dismissed as opposed to having their concerns at least listened to and maybe even evaluated.
Sure. Fascinating. I mean, all of it happens within a 10-minute span that the doctor might see the patient. It's so fascinating. Well, if someone wants to work with you, let's talk about both potential clients for advocacy and how they'll find you, as well as physicians who might be interested in cutting the line and taking your, coaching program. How do they find you?
The best way to find me is on my website, which is yourgpsdoc.com. That's where you can find information about my advocacy work for clients who may want advocates or advocacy services. For physicians, there's a button on there for coaching. So if there's a physician who wants to learn more about the coaching program, and then there's also for speaking and consulting. So everything I do is on the yourgpsdoc.com website.
Amazing. Dr. Nicole Rochester, thank you so much for being with us.
Thank you for having me. This was a great conversation.